Hello, I'm Lisa Guay-Woodford from the Children's National Hospital and the George Washington University in Washington, D.C. I'm really delighted to be part of the PKD Foundation of Canada's set of virtual meetings to provide patient education about polycystic kidney disease. I've been asked to talk about childhood PKD, and so I've entitled my talk, The Current Landscape and Future Horizon for Children with ADPKD and ARPKD. By way of disclosures, I serve as a consultant to Otsuka Pharmaceuticals. So I've divided my talk up into three major sections. First is to give you a brief overview about PKD. Second is to talk about the issues for ADPKD in children. So key issues in children, current treatment strategies, and the promise of targeted therapies. And then to switch gears and talk about the recessive form of polycystic kidney disease. Again, key issues, current treatment strategies, and the promise of targeted therapies. So to begin, let me give you a brief overview of the normal kidney. The kidneys are a pair of reddish-brown organs. They're located on either side of the spine, just below the diaphragm, behind the liver and the stomach. They truly are bean-shaped. Kidney beans, they truly are bean-shaped, and they're about the size of one's fist. The primary function of the kidney is to remove waste from the body through the production of urine. And they do this by filtering the blood, and then the filtrate proceeds through this long tortuous tube called the nephron. That's really a very incredibly smart structure that pulls into the body substances like, for example, calcium and sometimes sodium that are needed, and gets rid of excess amounts of sodium or other waste products. In this way, the kidneys help regulate the blood pressure, blood volume, and the chemical or electrolyte composition of the blood. So how do the kidneys help maintain health? Well, as I mentioned, they remove waste such as urea and excess fluid from your body through the production of urine. They continuously regulate the body's fluids and chemical composition, sodium, potassium, phosphorus, and calcium. They remove blood and toxins from the body. And they produce and release hormones into the bloodstream. So erythropoietin that stimulates the bone marrow to make red blood cells, renin, which regulates blood pressure, and calcitriol, a form of vitamin D that helps the intestine to absorb calcium from the diet and thereby maintain healthy bones. So the kidney handling of salt and water, as I mentioned, the blood is filtered at the level of the glomerulus. In terms of salt and water, there's about 1,500 grams of salt and about 200 quarts of water that are typically filtered by the kidney in the normal adult. But what's excreted is a very small amount of sodium, unless, of course, you're eating at McDonald's every day, whereby you don't need the sodium, and so the kidney dumps it. And about 2 quarts of water. So the kidney is a tightly regulated structure in terms of its function. In terms of the liver, which is also affected in polycystic kidney disease, the liver is one of the largest and most complex organs of the body, weighs about a pound in the average adult, and is made up of spongy mass of wedge-shaped lobes. The liver has many functions that are essential for life. It helps process carbohydrates, fats, proteins that are absorbed from food in the intestines and turns them into building blocks for the body. It secretes bile in these structures called bile ducts that help digest fats. In the factory portion of the liver, it makes factors that are needed for clotting. It stores vitamins and it breaks down toxic substances in the blood. And so when we think about polycystic kidney disease, we have to think about a couple of things. The first is genetics, and the second is what happens when genes go wrong that causes abnormalities in the kidney and liver. So let's start with the genetics. There are 2 major forms of polycystic kidney disease, and actually it's not adult and childhood. It has to do with the way they're transmitted. Autosomal dominant and autosomal recessive polycystic kidney disease. Now, a dominant disorder is one where one of 2 copies, because we have 2 copies of every gene, has a defect. And here we'll say that the defect is in the father, and he transmits 1 copy of this gene to each of his children, completely at random. In this case, this abnormal copy went to his son, who is also affected with this disease, in this case, dominant polycystic kidney disease. But every one of his children would have a 50% chance of inheriting this abnormal gene. Whereas in the recessive form of the gene, both copies of the gene have to be abnormal. So you have to get 1 abnormal copy from your father and 1 from your mother. By and large, one single copy of a recessive disorder, of a gene that's involved in a recessive disorder, doesn't lead to disease, by and large. There's a 25% chance that a given child will inherit both copies and therefore be affected. They may inherit one copy or no copies, in which case they wouldn't have any manifestations of the disease. So what goes wrong when you have these gene defects? Well, in terms of the kidney, we have to think about this nephron structure, and we have to think about the liver, but not the whole liver. We have to think about a very small portion of the liver, about 5% of the total mass of the liver. And that's this structure called the portal triad that has the portal vein surrounded on either side by bile ducts. That's the structure that's affected in polycystic kidney disease. So let's use that as the backdrop to talk about the dominant form of PKD. And again, as I said, it's a misnomer to talk about dominant PKD, or in fact recessive PKD, as adult and infantile PKD, because although ADPKD primarily manifests in late adolescence and adulthood, there is a clinically significant peak of patients that have significant disease that come to medical attention even prenatally. Whereas in ARPKD, while most patients are detected prenatally or in the first couple of weeks of life, there is a tail of patients who come to medical attention for the first time in late adolescence or in adulthood. So again, better to use the genetic designation for these disorders. Dominant polycystic kidney disease is where we'll start. It has a prevalence of about 1 in 800 to 1 in 1,000 live births. The molecular genetics primarily involve mutations in PKD1, a smaller set of patients with mutations in PKD2, and more recently, there have been several other genes that have been identified as causing ADPKD. The one that is most common after PKD1 and PKD2 is GANAB. In terms of the renal disease, this is a disorder that can affect, as I mentioned, both children and adults. The disorder itself, from a pathologic point of view, is here's the normal nephron structure. It involves these budding of these soap bubble-like cysts from anywhere along the nephron length. And what happens is these structures develop, and they get to be only 1 to 2 millimeters in size, and they close themselves off from the continuity of the nephron, and they continue to increase in size in an autonomous way due to a combination of secretion and cell proliferation, doubling of the cell mass. This can lead to kids with ADPKD having normal kidney size and a few cysts, all the way to kids and adults with ADPKD having lots of cysts and massively enlarged kidneys. Now, there are other associations for those of you who have families with ADPKD, biliary cysts that can be clinically significant and symptomatic, pancreatic cysts, vascular aneurysms, hernias, and male infertility. But by and large, these are not features that we see in children. In terms of ADPKD, I think it's important for this audience to recognize that even within a given family, there can be three different sets of presentations of ADPKD. There's, of course, the classic adult onset disease. There are children who come to medical attention not just because of an incidental finding on ultrasound, but because they have problems with blood in their urine, or protein in their urine, or high blood pressure. And these children have to be managed because they have clinically significant disease. And then there is this group of kids that have very early onset ADPKD that can occur, that can be manifest with imaging, in terms of imaging studies, even in the prenatal period, but in terms of clinical manifestations, right at the get-go in neonates, with hypertension and a more rapid progression of their chronic kidney disease, such that 25% of them in childhood will progress to end-stage renal disease requiring renal replacement therapy. This, by far and away, is the most rare presentation of ADPKD, but it does happen. In terms of the management of kidney issues, I want to call your attention to begin to the asterisks at the top of the slide. These are manifestations with management strategies that have been worked out for adults. From a pediatric perspective, we use many of these management strategies. We borrow them, if you will, from the adult literature because we don't have the clinical studies that suggest that these approaches are exactly the right approaches, or what the right approaches are for managing children. But by and large, they're a good place to start. I think as we go forward, there are efforts, as I'll talk about in a few moments, to really have data that comes specifically from children with ADPKD, and what are the best strategies to manage them. But for now, like in adults, we manage hypertension, we manage abdominal or flank pain, cyst hemorrhage, kidney stones, cyst infection, progression to end-stage kidney disease, again, very unusual in childhood unless you have that early onset form of ADPKD. Renal cell cancer, vanishingly uncommon in childhood. And then monitoring cyst growth. We actually can do that in adult patients based on some work that's been done in Europe and a separate set of studies done at the Mayo Clinic. But these kinds of models where we can quantitatively assess the severity of the renal cystic disease, those modalities are not yet available for children. So current management recommendations, and this comes from an international consensus statement that was primarily put together by a number of European pediatric nephrologists, is children with a positive family history should be monitored for hypertension and albuminuria. Notice, I'm not saying they should be screened by ultrasound, but they should be monitored, looking for clinical complications if they in fact inherited the disease gene. ACE inhibitors as the first line therapy for hypertension, for proteinuria, and for hyperfiltration. What that means is the kidneys are working overtime. They're working excessively hard, and those kidneys tend to tire out more quickly. And ADPKD children should be strongly encouraged to achieve as low dietary salt as possible, a recommendation that we as pediatricians and particularly pediatric nephrologists have for all children. In terms of targeted therapy, we know a lot about the biology of PKD, specifically ADPKD. We know that this receptor, kind of, if you will, sort of a baseball glove sitting on the bottom of the cell, catches the ball, which is vasopressin, and stimulates the production of this intracellular compound called cyclic AMP. And for a variety of reasons, in epithelia that are cystic, in polycystic kidney disease, the cells that are affected have very high levels of cyclic AMP. So we want to shut this down. And the way to do that is with an antagonist that basically blocks this glove so it can't catch the ball, if you will. And that drug is known as the generic form Tolvaptan and as the trademark Genarc, which was approved in the United States by the FDA in 2018 and earlier in Canada and in Europe. So this is a drug that's available, but for use in adults. We also know that the mTOR pathway, which is very involved in cell proliferation, is activated in various forms of polycystic kidney disease. And we have drugs that can shut down this activation. And so this is a drug that we refer to as a rapalog or everolimus. And then finally, we know that there is abnormal fluid secretion, or at least abnormal signaling events that occur from receptors that are on the urine-facing side of these epithelia. And again, we have drugs that can block that signaling from these tyrosine kinase, receptor-side tyrosine kinases. And the drug that has been applied for PKD is tesivimab, which has not yet gotten approval for any form of polycystic kidney disease, but is being studied in both the dominant and the recessive form of the disease. So in ADPKD, the recommendations for using any of these new therapies is that we don't have the evidence in children yet. So V2 receptor antagonists should not be offered routinely. When it's used in children who have very aggressive disease with huge kidneys, but it's used off-label. And I'll talk about a case in point in a minute. There's no consensus regarding the use of statins. I didn't have a chance to talk about that, but statins are part of the armamentarium that we bring to our management of adult patients with PKD. And despite animal studies that suggest mTOR inhibitors and somatostatin analogs can be useful in attenuating the course of renal cystic disease in these experimental models, they are not recommended for use actually at this point either in adults or in children. Now, there was a very important and illustrative case report several years ago from the UK. And here there was a little girl that was born with 2 abnormal copies of PKD1. And she had massive kidney enlargement, hypertension, low blood concentrations of sodium, and real problems with her respiratory effort. And she was treated with Tolvaptan from about 1 month of age through 12 months of age. And her sodium situation got better, her hypertension got better, and most importantly, her rapidly increasing kidneys were slowed in terms of their increase. So here's a human demonstration that was used as a last resort because this child had ADPKD. Tolvaptan was used off-label because of her very severe disease, and it seemed to have had benefit. So it provides a rationale for beginning to do clinical trials in children with ADPKD, at least that subset of children who have really significant and accelerated disease. So where are we with ADPKD in terms of clinical trials? Well, there are a number of clinical trials that have been launched. They are primarily in Europe in terms of interventional studies. And in the United States, the trials are primarily registries, or they are trials using nutraceuticals, nutrition supplements, such as curcumin. But this is in contrast to the over 120 studies that are being conducted or recently conducted in adults. So we have a long way to go for children with ADPKD in terms of clinical trials. Now, there is a very important study that is not an interventional trial. It's actually a registry. It's an international longitudinal registry of pediatric ADPKD patients, and it's called ARPKD. And it aims to collect data from large pediatric ADPKD cohorts in Europe, in Asia, in Australia, in Africa, and in South America. And we serve as the node in North America. And so for entry, these patients have to have a family history of ADPKD, or renal imaging data that is strongly suggestive of ADPKD, or genetic findings that indicate a defect in PKD1 or PKD2. And this is a protected database, so the confidentiality for patients is protected, but the goal is to try to recruit a very large cohort of children so that we can ask the very questions. Do ACE inhibitors work as well in children as they do in adults? Do ACE inhibitors and controlling blood pressure to a certain level work as well in children as they do in adults? What is that level? How do we think about hyperfiltration in children? And on and on and on. We need child-specific data to manage these children optimally. What's encouraging is of June of 2021, there were almost 1,300 patients enrolled in this study, and we are very happy to enroll Canadian children as part of our North American effort. So let's switch gears here and talk about ARPKD. So ARPKD, much less common than ADPKD. We've estimated from an electronic health record study that the incidence is about 1 in 26,500 live births. The molecular genetics, much more simple, primarily mutations in a single gene, PKHD1. The renal disease is very different. It involves fusiform dilatation of the collecting duct, both the medullary portion and the cortical portion, that leads typically to very, very large kidneys. In terms of ARPKD, here's evidence of one of those extremely large kidneys. This probably measures about 8 centimeters in size. It's from a newborn baby, where the kidney size should be probably half that big. And you can see all of these dilated structures, these striations, that's these dilated collecting ducts. In the liver, instead of the normal pattern with a portal venule surrounded by a beautifully choreographed lattice-like network of bile ducts, there's this really chaotic pattern that gives rise to what we recognize pathologically as congenital hepatic fibrosis. The reason this is a problem is because the portal vein brings blood back from the intestines, that nutrient-laden blood for the liver to work its magic as the factory of the body. And when this thin-walled vessel hits this intensely fibrotic area, there can be a reversal of this flow, into the spleen and to the blood vessels around the stomach and the intestine and the esophagus that we recognize as varices. Blood backing up into the spleen can cause the spleen to, if you will, become very hungry and start eating blood cells at an accelerated rate. And backing up of blood around the esophagus, the stomach, and the intestines can lead to varices, these thin-walled structures that are dilated and run the risk of rupturing and bleeding. So as I mentioned, we conducted an electronic health record analysis to estimate how many children there are in the US with ARPKD, because the numbers were all over the place, and how common a disorder is it. We, from genetic studies, had estimated that it occurred in about 1 in 20,000 live births. And you can see that from this analysis, we confirmed that it's about 1 in 20, 1 in 25,000 live births. We were able to, the first time, get a sense of what is the rate of perinatal mortality, which, if you go to the internet, suggests it's as high as 30 to 50%. We estimate that more recently it's about 21%, and that's because these children don't have appropriate lung development to survive outside the uterus. And then in terms of prevalence, and this is what's most important in terms of thinking about clinical trials, to sort of watch the clinical course of these patients, but also to be thinking about conducting clinical trials with targeted therapeutics. We estimate that there are probably about 1,500 patients just in the US alone. So a large number of patients that could benefit from further studies. When we think about patient survival, again, these are somewhat older data, but I think it continues to be borne out that if you survive the first couple of weeks, perhaps even the first couple of days with ARPKD, that there's long-term survival for these patients. And this comes from a study that we did in 2003 and a subsequent study that was done at the Mayo Clinic. So here, some perinatal mortality and then long-term survival into adulthood. In terms of clinical features in newborns, these children, for reasons we don't completely understand, are typically the product of spontaneous onset of labor at 34 to 36 weeks gestation, so they're a little early. These kiddos can typically have massively enlarged kidneys. As I mentioned, the level of sodium in their blood is low, and that's not because they don't have enough sodium, it's that they have too much water. It's a dilutional hyponatremia. That probably contributes to the hypertension. Many of these kiddos have decreased kidney function. Sometimes that kidney function can improve over the ensuing weeks or months. But the major issue for these kids is poor lung development, which leads to the 21% mortality rate. For children who survive the newborn period, again, chronic lung disease can be a problem for some of them, although it's very interesting that it's not as common as one would think, because a lot of these kids require a period of time on a ventilator, and chronic lung disease is not a major feature that we see in neonatal survivors. The kidney here, electrolyte abnormalities, hypertension can be an enormous problem, and declining kidney function over the course of childhood. The liver, as I mentioned, portal hypertension, that's scarring around the portal vein, leading to varices, which can bleed. And the epithelial structures in that abnormal constellation can be very chaotic. Those bile ducts can be very chaotic, and that chaotic bile duct system can be subject to infection, which we call cholangitis. In addition, probably because of the massively enlarged kidneys, these children can have real problems with poor growth, and feeding tubes are very often a mainstay of our management for these children. And there is a small subset of these children with genetically confirmed PKD that can have aneurysms both in the head and extracranial aneurysms. This is a handful of children, but there are numbers of places in the literature that say intracranial aneurysms don't happen in ARPKD, and that's actually not the case. There are a few cases that make the exception to that rule. In terms of clinical management, again, we're just beginning to get large data sets that can give us precise indication. These are from relatively small studies that suggest that these children have low serum sodium. That's again dilutional, not because they need necessarily more sodium because they're losing sodium. has to be an important consideration because that dilutional hyponatremia probably figures into hypertension, which is a very big problem for these kids. Urinary tract infections are a problem for these kids. Progression of chronic kidney disease all the way to end-stage kidney disease, growth issues, chronic lung disease, again, not a very high frequency, portal hypertension, and then, as I mentioned, survival and survival at this point is really quite good if one survives the perinatal period. Targeted therapies, you've seen this slide before. And that's because the biology for ARPKD is very, very similar to that for other renal cystic diseases, such as ADPKD. And so at least we have the insights to do clinical trials in this disorder. The problem is we're not doing any clinical trials. And the reason for that is because the disease onset is so early, it typically causes massive nephromegaly by birth. So everything in terms of timing is frame shifted to the perinatal period. But perhaps even more importantly, the kidney volume, which inexorably increases in ADPKD, and that's something we can follow and see if a given therapy will attenuate that rate of increase. It only increases in ARPKD till about 2 to 4 years of age, and then growth slows due to the secondary consequences of scarring and loss of nephrons. The kidney function is variable, and it's not necessarily well correlated with the disease severity. By that I mean the size of the kidneys. So the problem for doing clinical trials in ARPKD is we don't have any predictive markers of disease progression. So what's needed? We need international databases. This is a rare disease. We need to gather as many patients as possible, like we're doing in the dominant form of PKD in childhood. Pathobiologic insights, there are many, many common features that we can exploit for thinking about specific clinical trials. But there also are specific features of ARPKD that may provide windows into how we could design effective therapies. But most importantly, we need biomarkers of disease progression, clinical, biochemical, genetic, imaging, factors that we can follow to say, this is the natural history of the disease. We give drug A, and the natural history proceeds unattenuated. Drug A is not a good drug for us to use, but drug B attenuates the progression of the disease. That's the drug that we want to develop as a targeted therapeutic. So again, for targeted therapeutics, there is some drug repurposing, like we've done in ADPKD with Tolvaptan, originally developed for heart failure, but there also will be novel agents coming perhaps from specific insights about the pathobiology of ARPKD. So to get that large number of patients, there are several databases that have been developed in the world, and I'm not going to go through this in detail, except to say we're all talking to one another. We all have database elements that are common so that we can, if you will, take all of these component parts and do kind of super analyses that pulls all these different data sets together. And again, we are recruiting for children with ARPKD and ARPKD-like disorders here in North America. So what would be the possible benefit? Well, we're already starting to see some of the fruits of these database efforts. And this comes from ARPKD, which is the European ARPKD database. And what they were able to do is to take a large cohort of children, over 350 children, and they looked at these children in terms of prenatal abnormalities, like enlarged kidneys, renal cysts, oligohydramnios or anhydramnios, or a combination of all of them. And this is a sort of a complicated table, but let me cut to the chase by saying for those children who had oligo or anhydramnios, enlarged kidneys and renal cysts, there was a 32% risk of needing to have dialysis at 12 months and a 35% risk at 36 months if you had all three features. And I would contrast this with children who had ARPKD and no abnormalities. Prenatal abnormalities. Here, the risk is only 1.5% at 12 months and 1.7% at 36 months. So here is the first evidence that says ARPKD is not a single disorder, that as we've long suspected, it's stratified in terms of disease severity. And now with this database information, we're able to sort of make the stratification so that we can be thinking about these kids in more precise ways about what kinds of postnatal intervention they'll need. So in summary, PKD is a clinically significant disorder in children. While the polycystic kidney diseases are clinically distinct, many disease manifestations are common. Current therapy focuses on supportive management. Clinical trial design for targeted therapeutics has been hampered by the lack of prognostic and predictive markers, but research-ready cohorts are changing the landscape. And I think that's the real promise for both of these disorders going forward. For ADPKD in children, for ARPKD and ARPKD like disorders, that we're going to have the insights and the information that we need to develop the clinical trials to be able to evaluate and approve targeted therapies that will truly slow the course of at least the renal cystic disease in these patients. So let me start by acknowledging the folks that I have worked with at the University of Alabama at Birmingham and more recently at Children's National, our international collaborators, our collaborators in the US, and yes, we would welcome Canadian partners, and our funding from the NIH, from the PKD Foundation in the United States, and the Moran Family Foundation. Thank you very much for your attention. I'd be delighted to take questions. Oh, before I end, here's my contact information, my email address, and our websites. And I'm happy to field questions from interested families. Again, I can't discuss the specific features of a given child's clinical course or their management, but in terms of general information about the polycystic kidney diseases in children, I'm very happy to be whatever help I can. Thank you.